The topics today are really related to management of people who go through the parenteral route particularly and have to deal with some pretty complex issues in long-term management. So we're privileged to have Kara Caulkins speak, and Dr. Caulkins is an assistant professor in neonatology at the University of California, and she has had a significant interest in the pathogenesis of intestinal failure, particularly as intestinal failure affects the liver. And so that's going to be her topic, and we look forward to hearing it.
Good morning. It's certainly a pleasure to be here. I've heard a lot of great things about the Oley Foundation. So again, thank you for the invitation. I'm just going to wait for my slides. As the speaker mentioned, I am a neonatologist. It's the second set of slides. I am a neonatologist from UCLA. I've had a long-standing interest in nutrition, and specifically in parental nutrition and how it affects short-term and long-term health. And I've focused most of my clinical and research career on how lipids affect the liver. Let's see here. As far as moving the slides forward. There's not a computer up here, so usually I'm used to yeah, okay.
Is this it?
Okay.
Oh, see, I'm good.
Okay, perfect. Okay, there we go. All right. So let's get going. Okay, so over the next 20 minutes, and I'll make sure this is short and simple, we'll talk about different IV lipid formulations, or the different components in these lipids, and what in these lipids may be hepatotoxic, and maybe how we can change that in the future. We all know that parental nutrition is life-saving, and certainly it's revolutionized my field, pediatrics, and it's composed, or PN is composed, obviously, of sugar and protein, and lipids are a very valuable component of IV nutrition. So why are they important? For a wide variety of reasons. They're a dense source of calories, so you get a lot of bang for your buck when you give lipids. They provide fatty acids, and in fact, if you're not consuming food by mouth and you're PN dependent and you're not getting lipids, you can develop an essential fatty acid deficiency. They're really important for cell signaling. They help produce a lot of various hormones that regulate inflammation. And lastly, for children, some fatty acids, specifically DHA and arachidonic acid, are really important for neuro and cognitive development. And in fact, in the third trimester of pregnancy, the placenta preferentially transfers DHA and arachidonic acid. And if you're deficient in DHA and arachidonic acid, you can actually develop neurodevelopmental impairment or have issues with vision. And that's why formulas now have those fatty acids. So lipids are important, and specifically, some fatty acids are essential. But we know that long-term parental nutrition and the long-term use of lipids, specifically the dose and the different composition of lipids, are associated with something called intestinal failure-associated liver disease, which I'm sure most of you are very familiar with here. It's usually manifested by jaundice or yellowing of the skin, and we know that it can progress, particularly in children, to a cholestatic picture. In adults, you can see something called steatosis. But unfortunately, it can progress to fulminant liver failure. And children, specifically, are higher risk or have a higher incidence of this disease, and particularly preterm babies. And that's been one of my big interests, is why do preterm babies, or why do specific children get this disease? So what are the different fatty acids or lipid formulations on the market? And you all may be very aware of this. The most common and the only FDA-approved lipid formulation for children right now is intralipids. And this is entirely soybean-based. But there's a lot of other products available either under compassionate use or research protocols or outside the United States. Today we're going to talk mainly about omegaven, which in comparison to interlipids, which is entirely soybean-based, omegaven is entirely fish-based. There is a mixed emulsion known as SMOF that's gained a lot of popularity over the past 5 to 10 years and is commonly used outside of the US, and that's a mix of various oils. So as you may know, there was a landmark study that was published by Boston Children's by Dr. Pewter and Kathy Guru, and children with intestinal failure-associated liver disease, or children who were jaundiced and who were dependent on IV nutrition, when their soybean oil was replaced entirely with low-dose fish oil monotherapy, they saw that their liver function improved. In fact, their cholestasis biochemically reversed. And we replicated these findings, and other institutions have also replicated these findings, both in case reports but also in larger prospective studies. And we saw by about 9 to 12 weeks, the vast majority of children with advanced liver disease, we were able to reverse it by, again, discontinuing their interlipids entirely and replacing it with fish oil or omegaven. And again, this is another graph just showing about 75% of children respond to a course of fish oil, and we can reverse their disease within about 9 to 12 weeks. And we actually really believe this has made a huge impact on their long-term health and has helped improve the incidence or decrease the incidence of liver failure. So many people have asked what exactly is in this lipid emulsion or what's in omegaven that makes it different. And it's not just about the oils, but we'll talk about that. So omegaven, as I mentioned, is entirely fish-based. It has a very high concentration of DHA and EPA, and those are omega-3 fatty acids that are anti-inflammatory, where interlipids has a high concentration of omega-6 fatty acids in the form of linolenic and alpha-linolic acid. But there's two other things that are really important. One is that omegaven has a high concentration of an antioxidant known as vitamin E. And why is vitamin E important? Is it helps prevent lipid peroxidation, which damages cells. And as you can see here from this graph, interlipid has a small concentration of that antioxidant. In addition, omegaven or fish oil lacks something called phytosterols altogether, where interlipid has a very high concentration, and that's actually really, really important, and we can briefly talk about that. So as I mentioned, fatty acids, there's a difference between interlipids and omegaven. Omegaven has a high concentration of omega-3 fatty acids, which are known to be anti-inflammatory. And we know just from epidemiological studies that the amount of omega-3 fatty acids that someone consumes can have long-term health implications. It's associated with a decreased incidence of things like cancer, cardiovascular disease, diabetes, etc. So again, these two products have a very different composition of fatty acids that may affect not only liver health, but long-term health. So this is just another schematic showing the differences with regards to the fatty acids. Again, fish oil or omegaven has lots of EPA and DHA. So what we did is we actually measured the concentrations of these various fatty acids in children who were switched from soy to fish oil. And not surprisingly, both in the plasma and in the red blood cell, we saw an increase in the EPA and the DHA, which is the good stuff, and a decrease in the omega-6 fatty acids, which we think in this case was bad. And so interestingly, we also looked at the hypothesis or the thinking was, well, if we change the fatty acids, do we actually decrease inflammation? And in fact, we did. We saw a huge change in something called cytokines. And why is that important? Well, cytokines regulate inflammation, and that actually can be hepatotoxic. And in animal studies, they've shown that specific cytokines or inflammatory products can actually lead to biliary sludge or cholestasis. And that's in animal studies. So what we saw here in a small group of children was a remarkable decrease in these inflammatory products, which we thought was important. So I mentioned the difference in the fatty acids. The second thing to mention is the phytosterols. So phytosterols are plant-based sterols. They're very similar to cholesterol. You and I eat them on a daily basis. But when we eat them, we don't absorb them into our bloodstream. We only absorb about 2 to 4%. And those that we absorb, we actually excrete readily. They go out, they're excreted by the liver and into the stool. But someone who's using IV nutrition and who's being infused with interlipids is actually receiving a huge dose, a continuous dose, or a huge bolus of phytosterols. And the liver, particularly children, they may not be able to process it. And those phytosterols can accumulate, and again, those are hepatotoxic. So again, that's another element in interlipids that is certainly concerning. So again, as I mentioned, phytosterols, you and I consume them in the diet, but we don't absorb them from our intestine into the bloodstream. But a patient or a consumer who's being infused with interlipids is getting a large bolus of these phytosterols, and those, again, are hepatotoxic. And we've known for decades that if you're on IV lipids, specifically interlipids, that as your phytosterols go up, your liver function tests also go up. So just like with the inflammatory products, we measured the concentrations or the levels of these phytosterols in children before they received fish oil, so while they were on interlipids or soybean oil, and then during their course. And something to sort of point out here is if you were to measure the various phytosterols in my blood right now, they'd be less than 0.5. The concentrations in these children were incredibly high. They were well over 10. That's actually akin to the concentration in a child who has a genetic disorder known as cytosterolemia. These are really hepatotoxic concentrations. And then over time, and by 3 months of fish oil monotherapy, we saw a remarkable decrease and a return to normal concentrations. And so why is this important? I know this is sort of a busy slide. The take-home message really is that inflammation and phytosterols inhibit specific transporters in the liver that help you excrete bile and bilirubin. And that's really important. And so when you're infusing these products that may be pro-inflammatory and have high phytosterols, you're going to increase the likelihood of developing liver disease, particularly in children and particularly in babies whose livers are immature and cannot handle these products. So there's always a big debate in my field, or what is it in interlipids or in soybean oil that's hepatotoxic? Is it the fatty acids? Is it all about the phytosterols? Or is it about the antioxidant? And it's probably about all three. And I think we can't just pick one. It's a multifactorial disease, and when we look at lipids, it's even more complicated than we think. And so this is just sort of a summary, or the take-home message here, is that when you have lots of phytosterols in your blood, and you have lots of inflammation, whether it's because of infections or because of the lipid product, all of this can lead to a diseased liver or the accumulation of bilirubin, which causes cholestasis and eventually jaundice, and lead to the deposition of fat in the liver, which leads to a fatty liver. And that's sort of the thinking behind why specific lipid products are not good for the liver and why other lipid products may be better. So in conclusion, IV lipids are an essential part of parental nutrition. They're incredibly important for short and long-term health. I think the research that's been performed over the past 10 to 15 years has really given us a better understanding of one of the major complications in pediatrics associated with long-term parental nutrition, which is intestinal failure-associated liver disease. And hopefully in the near future, there'll be more and more new lipid formulations available to consumers to help decrease these adverse effects. So thank you so much for your time, and I'd be happy to take any questions.
I should share with the audience that was a brilliant, short, beautiful presentation.
Thank you.
Terrific. Yeah. So let me just ask one question, because I think we all know that before too long, SMOF may be on the American market. And SMOF, as Dr. Caulkins pointed out, is a combination of fish oil and some other oils. So what is your feeling about something that's in between?
Sure. I think the introduction to SMOF is incredibly appealing and exciting for a lot of reasons. So one is, as a neonatologist who prescribes IV nutrition to babies all the time, we're looking for something in the middle, so something more akin to breast milk. And when I think of interlipids and I think of Omegaven, they're on one side of the pendulum. You know, here's interlipids and here's Omegaven. And SMOF is sort of in the middle. And the composition, or the fatty acid composition, is more akin to breast milk. The second thing is that SMOF can be dosed at 2 to 3 grams per kilo per day, where Omegaven's dosed at 1 gram per kilo per day. So there's a lot of concern about growth with fish oil monotherapy. So I think SMOF has a lot of potential to help promote better growth and neurodevelopment, particularly in children, and also maybe less hepatotoxic. And certainly there's some literature that already supports that.
So how many people in this audience have been on these fish oils or have children that have gone on to these fish oils? Quite a few. And so we would perhaps like to hear from you about how hard it was to get onto them and how things are going.
I just had a question. I found your presentation extremely interesting.
Oh, thank you.
But and I've been busily taking notes. But in conclusion, what should the lipids consist of?
Sure, that's a great. So I think lipids need to have balanced fatty acids. They need to have a physiologically appropriate fatty acid ratio, so something like 2 to 1. That's what's recommended by most health organizations. Interlipids is more like 5 or 6 to 1, so it's really unbalanced with a lot of omega-6 fatty acids. The second is they should not, or they should have a very minimal concentration of phytosterols. Phytosterols are hepatotoxic. Again, you and I eat them, and they actually serve a health benefit when they're fed enterally, but when you're giving it intravenously in a large bolus, particularly to children, they can't clear those phytosterols for lots of reasons. And then the third thing is lipids have to have an antioxidant, because lipids will undergo something called lipid peroxidation. And it sounds like a very simple or fancy name, but lipid peroxidation causes cell damage. So you have to have an antioxidant in that formulation, and you need a good antioxidant. And you need vitamin E in a high concentration in the form of alpha vitamin E. Right now, interlipids mainly has gamma vitamin E in a very small concentration. So those are sort of the three main things that I could see that could benefit consumers with regards to changes in lipid formulations.
I think one should add that when we give you your multivitamin intravenously, we are giving you alpha vitamin E, so it's not as if you really don't get it. Question, another discussion point.
That's as good as it gets.
We're the parents of a now 10-year-old who started on Omegaven at 1 year old, and it was very easy to get, actually. And it reversed his portal hypertension and allowed us to put a G-tube in. So we waited until the point that we absolutely needed to make a change because we didn't know, it was so new, but it saved his life with the Omegaven.
Does anybody else want to talk about their experience? Yes? Either getting on or what it did when they got on?
Yes, our daughter was born at 32 weeks as a twin, had neck, lost a good bit of her bowel, and was on intralipids for 2 months, and looked exactly like her numbers. Her direct bilirubin was high, total bilirubin high. She looked jaundiced, and we were transferred up to Stanford, got her on Omegaven, and it's textbook, just like your charts. Within 8 weeks, her direct bilirubin was gone. Her total bilirubin was less than 2. Just a textbook example. So we're very fortunate that it saved her life, probably. And I guess the question, I thought it was very special for us to get opportunity to have that. But if there's any advice you can give to folks who aren't aware of it, or at our less known hospitals, and or away from places that could bring this up and raise awareness, because it's definitely helped us.
So I think you bring up a really important point, is the access to intravenous fish oil. So As of today, unfortunately, Omegaven is not FDA approved, so the only way to gain access is through a compassionate use protocol or a research protocol. When we started using Omegaven over 10 years ago at UCLA, we were one of the first west of the Mississippi to provide it, but now in the state of California, there's a handful of institutions that do provide it, all the way up to Stanford and all the way down to San Diego. But as a clinician and as a researcher, I still have a lot of concern about the lack of access to this drug. Many families may not have the resources. They may not even know that this exists, and that may be because their clinician may not present that opportunity or may not know about it. Even if they do know about it, the next question is how will they get to an institution that can provide it? So for example, in the state of Arizona or in Nevada, there isn't an institution that provides it. So we do take care of children who come from those states. That's a huge financial burden to families. And then you can imagine there's some families that lack access altogether. So I think this sort of speaks to the state of healthcare and the need for better access to products that may be life-saving. But some parents or some families don't have the same experience where it's not as easy to get, unfortunately.
I was just going to say, my daughter also is on Omegaven. She's 6 years old, and she started on it about 4 months old. We also go to Stanford, and it was, at the beginning, it was easy to get. Insurance approved it. Then at one point, our insurance decided they weren't going to, there was a contract negotiation with Stanford, and then we got the letter saying we couldn't go to Stanford. So we were wondering, are we going to have to drive to UCLA 5 hours, or how are we going to get this? Then contract negotiations, came through. Then this last year, we got a letter from the insurance saying we're denying this. All of a sudden, over 5.5 years. So then we had to jump through a lot of hoops, writing letters to the insurance, getting back another denial, and then finally we had to go through CCS, but it was kind of scary getting they're like, oh, we'll give you a estimate, and seeing the estimate was huge sticker shock. Even if I sold my house, I couldn't afford it for a year. So there is a lot of, it's kind of scary just to think that it's not widely available, and it does save lives.
See, unfortunately, it's not FDA approved, and so without an FDA approval, technically insurance agencies or third-party payers don't necessarily have to provide reimbursement. And the question is when will something like Omegaven or other agents like SMOF be approved by the FDA, either just to better nourish children or patients or to help reverse liver disease as a rescue therapy. But unfortunately, it's not FDA approved. There's never been an RCT, a randomized controlled trial. At this point, it's probably unethical to do a randomized controlled trial, in my opinion. So we won't have that data, but I think there is a predominance of data from various institutions to support the efficacy of Omegaven. There are, as far as safety, it's relatively safe, but one thing to always remember is that fish oil can increase the risk for bleeding. It causes platelet dysfunction, and that's something to just sort of be aware of, and we're very cognizant of that at UCLA. So that's always something to discuss with your clinician, is that increased risk of bleeding, particularly in the face of advanced liver disease and portal hypertension.
I just have a quick comment. With your story, it seems like you're at a good place now, but there's always a reason to advocate for yourself. Introduce yourselves to your lawmakers. Talk about your situations and how you got there and the ups and downs, and help them understand so when they're voting on legislation or they have connections with the FDA, they can bring your story forward. There are a million reasons why we need to be activated in doing these things.
Let me just push another button, Dr. Caulkins. What is certainly the case is that if you can switch your child or your individual from intravenous fat to an oral diet, you can also clear the jaundice pretty fast. And so the the tough issue is always, especially in a very young child, is how much can you push anything enteral? What is your experience in that way?
So that's absolutely true. So the whole goal is to get off IV nutrition, but you have to do that safely without compromising hydration and nutrition. So in our view at UCLA, if we believe a specific child will be off IV nutrition within a reasonable time frame, most likely we would not initiate IV fish oil. But if we have a child who has clear and definitive intestinal failure, and we believe that intestinal failure rehabilitation will take several months to years, or may not even be possible, that would be a child who would be a great candidate for fish oil to help reverse the disease or protect the liver. But first and foremost, I think with IV nutrition is if you can get off of it, you get off of it, but it has to be done safely and methodically and under the care of a good clinician. And you also always want to prevent infections. Infections are hepatotoxic. So again, I always tell people it's not just about the lipids, it's really about some other components. Enteral nutrition and infections are really important to remember.
I just make the point that most clinicians would be trying from both aspects.
Absolutely.
Right from the beginning. It's often tough if the child actually in utero didn't develop a proper swallowing mechanism because they were obstructed. That takes quite a long time, actually years, to fully recover, and so tube feeding can be very difficult in that situation. But a short bowel that just occurred from an acute torsion or something else, you often can start using that gut straight away with a tube at least.
Absolutely.
I am? Oh, okay. Thank you. Great presentation, but my question is, when do you transition from fish oil to maybe intralipid, even small amounts, or do you, as the kiddos get older, are we waiting for SMOF to be the transition lipid? Tell me about that.
I can just briefly sort of talk to you about our experience at UCLA. So we use Omegaven in 6-month intervals, and that's because when Boston published their data and when Toronto Sick Kids published their data, they showed that they could reverse the disease in the vast majority of patients, about 75%, within 6 months. And then we saw the same thing at UCLA. So we continue to use it in 6-month intervals. So that means children who are pee independent after 6 months of fish oil go back onto soybean oil. They usually go back onto low-dose soybean oil, and there's probably a lot of reasons why low-dose soybean oil may be better than high-dose soybean oil, and we can certainly talk about that. We've actually followed these children for up to 5 years to see if their disease reoccurs and how many children actually have to bounce back onto fish oil. And we do see a decent reoccurrence rate, particularly in the children with, again, clear and definitive intestinal failure. So those children who don't make any progress on their enteral nutrition. But we have stuck to this 6-month intervals for a lot of reasons.
I just wanted to ask, for the lipids, if you're allergic to soy and you're allergic to fish, are there other options? Are there other things they're working on?
So I've heard of children who are allergic to soy. I have not met someone who's allergic to Omegaven yet. I don't know if you have that case. As you saw, there was various other lipid formulations that are composed mainly of olive oil and coconut oil. And some of them are available or FDA approved for adult use, not necessarily for children. But the main products now are intralipids, SMOF, which does contain fish and soy, and Omegaven.
Well, if that's the end of the questions, that was terrific.
Thank you.
Thank you so much. Yeah.